This is the May Ethics for Lunch. My name is Mark Hughes. I co-chair the Hospital Ethics Committee and also a faculty member in the Berman Institute of Bioethics. For those that are unfamiliar with Ethics for Lunch, this is a monthly series co-sponsored by both the Ethics Committee and the Berman Institute of Bioethics. An opportunity to present a topic of interest here in the hospital and invite input from you all, our hospital community, about these topics, and generally we present with cases that you can also react to. So today's topic is going to be when a patient's refusal of an aspect of care affects their overall treatment plan. In March, we talked about informed refusal by patients, deciding not to go with a proposed treatment by a clinician. In this case, they might make initial agreement to a treatment, but then there might be aspects of that care plan that either on a daily basis or a periodic basis they seem to refuse or not adhere to the plan that's in place, and that might impact on the overall course of the treatment or present some impediments to them actually achieving the success that they had hoped for in agreeing to the treatment in the first place. So we're going to talk about a few different nuances to that idea as we go through the cases. Maybe what I'll do is, are you good there? And I'll just show my introductory slides, and then we'll bring up the panel after I've shown those. So one way we think about ethics, and I'm just trying where my cursor is basing it on the principles, ethical principles, beneficence, non-maleficence, respect for autonomy, and justice. And in that regard, there are models for how to organize those principles when we're thinking about a particular case. So for today's objective, just to highlight it again, identify key ethical principles and values in conflict when patients refuse aspects of their treatment plans, discuss strategies, number one, to try to avoid those refusals if you're really trying to reach agreement with the patient. But if patients do introduce some barriers to instituting standard of care recommendations, what are the strategies we use to engage them, work with them, communicate with them to achieve the outcomes that they want? So the University of Washington, in their ethics program, this is based on a book by Johnson, Siegler, and Winslade, and they call it the four-box method. So it breaks it down into medical indications. So what are we trying to achieve for the patient, their best interest medically? What is their condition? What are the treatments that are being proposed? What are the chances of success of that? How do we avoid harm in instituting those treatment choices? Patient preferences. How do we think about the patient's voice, their decision making? Do they have the capability of making their own decisions? Do they need to rely on someone else to make those decisions? What are their preferences, the recommendations that are being made and the alternatives that might be proposed? Quality of life sometimes becomes important when people are facing serious illness, might need to be hospitalized. Again, what are the probabilities of success? Are there any opportunities to think about the quality of life as they're in the hospital, but also after they leave the hospital? How do they view their functionality? What if things don't go the way we propose or hope? What are going to be measures instituted to address their quality of life? And then there may be a whole host of contextual features, both from a patient and family perspective, cultural background, religious beliefs. There might be issues with regards to the healthcare team or the institution that they need to pay attention to, and how do those bear on the treatment decisions for a particular patient. So it's a nice way to sort of summarize thinking about the facts of the case to try to help then elucidate the principles and values that should be the cornerstone in making the decisions. As I've said, beneficence is promoting welfare and best interests. Non-maleficence, first do no harm, so avoiding harm to people. Respect for autonomy is often, the hallmark is going to be that informed consent process. giving them enough information that they understand, can process that, and then come to a decision. And then justice, the other principle, is all about fairness. And there are various ways that it can be framed. Egalitarianism would say each person should get an equal share. Across the board, everyone gets equal. Sometimes we'll say, well, those that are more in need should get more of the resources. So when we're distributing it, those who are more needy might be given more. Sometimes society is based on merit, or who can pay, who has the resources themselves to pay for it. Or the other one that we commonly use is first come, first serve. So we stand in line, the first person in the line gets the resource first, and then it goes down the line. So as you think about justice for any of these particular cases, one of the resources I want you to think about is time, especially the time invested by the healthcare team. So if there's been an initial agreement to a treatment plan, and then there are refusals or impediments along the way, the team has to invest more time for that patient to try to convince them, communicate with them, understand where they're coming from in order to reach the goals that they want to achieve. So we break this down. 4 boxes, I just want you to remember these points from each box. For medical indications, what are the goals of treatment? The patient preferences. Does the patient have capacity, and what are their preferences if they don't have capacity? Who's speaking on their behalf? Quality of life, what are the prospects with or without treatment for return to a normal life? And normal life is as defined by the patient. What do they consider normal for themselves? And then contextual features, are there issues that might affect their treatment decisions, either from a family perspective, from a private perspective, cultural, religious, or even financial background. The other thing I wanted to just set as a context for some of this is when patients come to the hospital, they have rights and responsibilities. The foremost right is the right to have informed decision making. So we give them information about their treatment options, they're informed of that, and then they make the decision. But they also have certain responsibilities if they're a patient here that they have to follow through on in order to get the outcomes that they do want to achieve. So I'm not going to go through all of these, but I wanted to highlight a few. If you ever looked at the patient rights and responsibilities in our Hopkins Policies Online website. And this is given to patients when they are admitted to the hospital. So again, very important elements in terms of their rights: considerate, respectful, and compassionate care, having their culture and personal values, beliefs, and wishes respected, getting information in a way that they can understand. The information is about their diagnosis, test results, outcomes of care, any unanticipated outcomes of care, overall being involved in their care plan, and also that includes their discharge plan. If they wish to, have their family involved in the care. If they ask questions, patients should be able to get answers, and any requests that they make should be addressed. One of the elements in their rights is having their pain managed. They do have the right to refuse care, so that stands as an individual autonomy that they can refuse care. Have someone there for emotional support, and this caveat that the person can't interfere with either the patient's or others' rights or safety or health. So there have to be certain hospital rules if they have other people involved in their care or are there for emotional support, that they also have to adhere to certain hospital rules. And then giving permission, so doing the informed consent. They've been informed about risks and benefits, alternatives, as well as the risks and benefits of the alternatives. On the other half of things are patient responsibilities. And for those, I'll just highlight a few. So patients on their end, as much as the clinicians have to give information to them, patients also have to give information to the clinicians. So accurate and complete information about their health. They have to be respectful of the team, the doctors, nurses, technicians, people who deliver meals, the managers, everyone in the hospital that they interact with, they have to show respect to. Being considerate in language and conduct of other people and property, including being mindful of noise levels, privacy, and number of visitors. If they're feeling angry, being in control of their behavior, again, as a sign of respect. They don't let their anger come to the surface and then really disrupt their care plan. If they have an advance directive, making that available to the hospital and clinicians so that can help if they lose the capacity to make their own decisions. Making sure they're asking questions if they don't understand anything. If their health condition changes, that they report that so that, again, the treatment plan can be altered. Following the hospital rules. And if they do refuse treatments, taking responsibility for the consequence of that. Or if they don't follow the instructions as outlined, that they also take responsibility for what happens, that they've been informed of potential outcomes and the risks and benefits. All right, so with that, I'd like to have our panelists come up and have them introduce themselves.
Hi, I'm Nicole Gudzowski. I'm a member, a community representative on the Ethics Committee, and I also serve on the Patient Family Advisory Council. I got involved in that volunteering after a few years of helping manage my parents' care in New Jersey. Unfortunately, we didn't have issues with refusal of care, although upon being admitted to the hospital, finally, because my dad was very stubborn, he decided he wanted me to go home and get his medication instead of having the caregivers give him this medication. And, it got to the point where the nurse felt she had to call security. So that was unfortunate. But we didn't have a lot of issues with refusal of care, but I hope to provide some perspective today.
Good afternoon, everybody. I'm Jeff Natterley. I'm the risk manager for Johns Hopkins Hospital. I'm one of the attorneys for the health system. And I'm grateful to be here and talk about this topic, which, as some of my colleagues in the audience know, we get this question a lot when it comes to legal advice about what to do when somebody refuses care. So I'm looking forward to the conversation.
Hello, my name is Shannon Barnett. I'm a child psychiatrist. I'm on the Ethics Committee and also in the program to get a candidate for my Master of Bioethics. I'm really interested in particularly outpatient, so I'm doing, right now I'm in the middle of a qualitative project, talking to patients and families about how they want providers to interact with them when they aren't following kind of our recommendations. So I'll talk a little bit about that.
Hi, my name is Lisa Holloman. I'm a social worker on medicine floor on Meyer 9. And I often work with patients who refuse care.
Hi, I'm Sharon Owens. I'm a nurse practitioner in cardiac surgery, assistant director of nursing, and I'm a member of the Ethics Committee.
So in your handouts, you have the 4 cases. We're not going to read all the cases. I'll give you a very quick synopsis and then we'll get into our panel's reaction to them. So case 1 is a patient admitted with a bowel obstruction, is found to have a mass in their colon. There's suspicion that it might be cancer. In order to get a biopsy, they require a bowel prep to clean out the colon, and the patient refuses to have that done. Tries, but is unsuccessful, and the team tries to work with the patient to figure that out. Case 2, elderly woman with advanced dementia. She's admitted with a lot of medical problems. She has a pressure ulcer on her sacrum, needs wound care for that. In her dementia, she's not really aware of what's going on around her. She's combative. She interferes with the nursing care that needs to be done on a daily basis. Nurses are concerned that she might be in pain. Her family, who's speaking for her, making decisions for her, is refusing pain medication. So how does the nurse and the whole team manage this patient? Case 3, gentleman with lots of medical problems, chronic medical problems, has been in the hospital for a long time. There's certain days he's on dialysis. On certain days he refuses to go to his dialysis sessions. Usually it's a 3 times per week routine, and on certain days he might say no, which then impacts his other aspects of his care. He might have electrolyte disturbances, he might have fluid management problems. So his particular refusal on one day, then he has to be worked into the schedule either later that day or the next day. It's going to just cause problems for working towards getting him better to get to a rehab facility. And then case 4 is our outpatient case. So a teenager with mental illness, trying to work, the clinician trying to work with the parents and the patient herself to get the medical care she needs to manage her mental illness. Some of that's medication, some of that's behavioral management. Parents aren't completely on board with instituting the measures that are being recommended by the clinician. How do we deal with that? So that's the quick synopsis of all 4 cases. I thought I'd start with Jeff in responding to case 1. So a patient that needs a procedure but is refusing to do the things necessary for the procedure. If you were called, the clinician called you from a legal perspective, how would you walk through that?
Thank you. Gosh, I had that call today. I get the call pretty much every day about something like. I think number 1 is the easiest of the 4 cases, to be honest with you, in some way.
And here, back here, could you have a mic?
Sure. Can you hear me now?
Yeah.
Okay, so I'm calling on people in the back too. Just a second. The bottom line is, and I like how you presented the whole ethics for lunch with all the patient's rights and responsibilities, because every patient has the fundamental right to refuse care. Also, I think it's incumbent upon providers to make sure that they have a discussion with the patient relating to all the alternatives, depending upon what the clinical scenario is and what the requirements would be to do a proper diagnosis. So for instance, in case 1, where you have somebody that I'm sure has some emotional stuff that they're bringing to the table as they're going through all of these conversations relating to diagnosis of potential cancer. There's so many intangible pieces to this that go into why somebody's refusing care. And oftentimes, whether it's me or one of my colleagues that get this call, we will walk through with the clinicians as much of that background information as possible to try to understand why there's a refusal. Because ultimately, it's not the attorney's decision to force a patient into doing something that they are refusing to do. It's the patient's fundamental right. But the types of things that we talk about are how to negotiate with the patient, what the outcomes would be of that refusal, what the clinical outcomes would be of that, or the lack of ability to properly diagnose under those circumstances. Then also what the alternatives are when you are faced with a situation where you can't do a proper valve prep to get a proper biopsy. What's plan B and what's plan C that may be more amenable to the patient, as long as the patient also understands what the risks are of those alternatives as not being perhaps as accurate a methodology for getting the kind of information that they need. So we would tend to walk through all of those different things. And to be honest with you, the first question that any of the attorneys that gets this call will ask is, does the patient have capacity to make those decisions? It really is a fundamental question to ask, and whether or not there's been a capacity assessment done for the patient, because then the decision making under the law would fall to a surrogate. And I also want to point out, by the way, I'm very excited about this topic, as you can probably tell. Even incapacitated patients have the fundamental right to refuse care. Just because they're incapacitated, you're not going to sit on the patient and jam an edge tube down if they're fighting you on it. And so we try to make that clear to the clinicians too, that even if you go to a surrogate for decision making and the patient lacks capacity, there's the right way to perform the procedure and not such a right way to do that. So from our perspective, I think ultimately what it comes down to is the messaging to the patient about what the different options are. And also, one of the things, Mark, that you pointed out perfectly in the beginning, is as part of the informed consent process, you do have to have a discussion about alternatives. I think we kind of gloss over that sometimes when it comes to what the options are. Because the standard of care is X, so we're going to do X. And I also think there's a huge difference between collaboration and coercion. So we're very mindful about browbeating a patient into doing something that they're adamantly refusing, where it crosses the line into coercion. And so as legal advisors, we kind of walk through that as well. I'll stop there.
Any reactions from our panel? The lawyers turned it back to you. Just find out why the patient is refusing. Can you work with alternatives? Thoughts about how you approach the patient?
So as a social worker, I would go and talk to the patient and try to ask him or her, why are you refusing? Is it external things? Is it things that are happening in the hospital? Are you not having confidence in your team? Is it something that a lot of times teams change in the hospital, so they might be bouncing from one floor to the other floor. So is it because you're with a different team now? Is it something that you don't have trust with this new team? I would also ask if they have any, like who their important people are in their lives, their family, their friends, and try to get those people on board to help them work with the patient to see if they can convince them to go along with the plan of care.
I think, the nurses are probably the people that spend the most time with the patients, so they may have a relationship with the patient and a level of trust that other people on the team might not have. So kind of also reinforcing that, who are the people that you want to help make decisions? Is there something specific that's holding you back from doing this? Is there something else we can do? Is there some alternative, and trying to negotiate with them?
There's a type of therapy that we do in psychiatry called dialectical behavioral therapy, and one of the rules is to do 3 validating statements for every 1 change statement. And I think sometimes as clinicians we do lots of change statements and not so many validation statements. So I think also whenever there's conflict with patients, I think just making sure, kind of even counting to yourself how many kind of validation statements are you doing per change statement. So I think a 3-to-1 or 4-to-1 ratio is actually a good way to think about it, and probably hard to do.
Can you give examples of what a validation statement and a change statement?
So I think a validation statement may be the stuff you have to drink for your bowel prep tastes disgusting. We get that complaint all the time. Or maybe you're scared, you look like you're scared or nervous, or I heard you talking about being nervous, or those. And then change statements are maybe, how can we help you drink this today, or drink this tonight? Are there things we could do, like reminders or things like that?
So Jeff, I'm curious, the questions that you ask of clinicians, do they generally have the answers? Is it something they have to go back and get? Because I guess my point in all of these cases is that, trust is built from the moment somebody walks in the door, and if, there isn't an authentic introduction, if there isn't active listening, it's very easy for patients and families to lose trust. And we don't know what this particular individual's experience is. Maybe his father had a colonoscopy and found out he had cancer and died, and it was a horrible experience. So, I know time is always so precious, but getting those stories is critical.
So there's a spectrum of responses, and it varies from clinicians who have got long-standing relationship with patients, who may have other experiences of other refusals that then get to a point where they feel like they're at the end of the road with this trust relationship with the patient. We have a lot of those calls as well. And then, a lot of these calls are like really bad Venn diagrams. And so oftentimes we'll get information from one provider and then social work and then the nursing staff. And what we try to do is work with the team to cobble together, bringing those circles together to find out what the reality is or what maybe the data shows. As some folks have heard me say often, it's a capital mistake to theorize without data. Most of that data in these situations really come from a combination of, first and foremost, the patient's family, collateral information, the medical record, the history. So much data is out there that I think sometimes we don't call as we're coming to a plan for this. Sometimes it works like a dream, and I've had one provider call once who said, "I'm fed up with the patient, I'm going to terminate this relationship." As a result, we get a lot of those calls actually. I don't know, I see Susan sitting in here and some other folks. I mean, we probably get 6 to 12 calls to terminate relationships a week. Oftentimes, I'm sorry I'm blathering, but what we'll tell the providers when we start teasing out, okay, why do you want to do that? Like, what happened here? And oftentimes the recommendation back to the provider is, have you gone back to the patient and said exactly to them what you're telling me? Because you're talking to a lawyer for the hospital, have you had the same conversation with the patient? And a lot of times the answer is, not completely. I'm like, well, why don't you go back and here's some talking points. And I remember one case in particular where the provider was moments away from just terminating the relationship and sending the patient to Maryland or Union Memorial, and they had a frank conversation, and they completely flipped it around and developed a very trusting, frank relationship. So I think it depends on providers and data.
So case 2 involves a patient that doesn't have capacity, can't really talk to her about her behavior or really trying to determine if she's in pain. You can sense by grimacing or other things that she might be in pain with doing wound care. But as Sharon said, the nurses are with the patient most of the time for the day. So how, Sharon, how do you think nurses should think about this case?
So I think, initially the concerns, you can see this kind of from the nursing staff and from the providers, is that what they really want to do is to be able to provide the care that this patient needs and to make her comfortable. I mean, nobody wants to feel like they're harming a patient. So I think that's sort of where the origin of the distress for the staff is. So once I think it's been determined that the patient does not have capacity, has that patient identified a healthcare agent, and if not, who then is the appropriate surrogate. In this case, it happens to be your daughter. It may be another family member in other cases. But I think some of it too for surrogates is, do they really understand what it means to be a surrogate? They're not making decisions for themselves. They're making decisions for that person and how that person would make them. And I think that's hard sometimes for all of us to understand if we're put in a position where we have to make decisions for somebody else. In addition to that, I think it's are there clues, trying to find out from the patient's daughter of what this patient would have wanted if she could really speak for herself. Does she want to be comfortable? Does she want some other kind of pain? Does she want pain medicine? Does she want some other sort of pain relief? What were her goals? And trying to figure out, is this her being combative? Is that part of her illness? Is it because she's in pain? Trying to negotiate with the surrogate and trying to help her understand that we're trying to make your mother comfortable. We're trying to do these treatments that ultimately are going to get her better and get her back to her home. So kind of how can we work? How can we negotiate with each other? But I think really trying to educate the surrogate and say, you're making decisions how your mother or your loved one would have done.
Other thoughts from the panel?
One of the thoughts I had with this case is also, it sounds like the daughter's really worried about her mother's mental status and how alert she is. And so I do think the team can really work with the daughter on those concerns, which are valid. Are there medications that are going to have less effect on her mental status? Are there ways that they can test, like, test her mental status before she gets the pain medicine and afterwards, so that the daughter knows that if it's having a significant effect on mental status, that they won't continue that particular medication? So I do think, in this case, really working with the daughter's goals, which are to have her mom as alert as possible, and seeing if there's ways to reach both the daughter's goals and the nursing staff's goal to decrease the pain and make the patient comfortable.
I think sometimes too, as clinicians, we always want to give people the facts, and we say, well, we've explained it over and over and over again from a clinical perspective, but I think sometimes it's important to step back and say, they're not necessarily making a decision based on the clinical piece of it. There's other things. There's, sort of their emotional response to seeing her mother this way, and or spiritual, or other goals and values that they have that aren't necessarily going to be tied into what our clinical issues are.
Yeah, I was just going to add to that, there may be a cultural or religious reason for them not wanting to give her pain meds. And I think that would involve a conversation between the team and the daughter of what is it just because you want her to be awake, or is there something more? Has this been something you guys have talked about in the past?
Unfortunately, I know a lot about wound care, and it's kind of interesting to think about somebody not wanting the wound, somebody to be able to get the wound care, because we were always like, when is the wound care coming? Because we knew how important it was. I listened to this case, and I think, well, this is an opportunity for the family to speak with somebody from palliative care. Both in the case of my mother and father, we were offered that opportunity. We didn't know better to ask for it. Too late, but it was really then when we were able to understand how best to make decisions in a way that they would have wanted. Atul Gawande quoted a palliative care doctor who said, "The family discussion is my most important procedure," and it sounds like that's the procedure that would be needed here.
All right, moving to case 3. Now it's a patient has capacity, but on a day-to-day basis might have certain refusals in their care plan. I'm just going to throw it out to the panel. Lisa, do you want to say how you handle this one?
Yeah, so I would talk to the patient again, ask, are there external factors? Are there reasons why you're refusing dialysis? Is it over lunch break and you're missing your lunch? Is it something that we can do as a hospital to have you on a schedule that you want to go, or you're at least willing to go? In the case as well, I think he was a failed kidney transplant, yeah. So is he just demoralized? Is he to the point where I've done dialysis, I know what this is like, I don't know if I want to keep doing this again? Would he want to talk with social work more, or the chaplain, or palliative care team, or something more, do you want to continue doing this? I also talked to him about, is there a physical reason? Is it making you ill? Is it hurting you? Is there a reason why some days you say, yeah, I feel okay enough to go, and other days you don't feel well enough to go? And then I think finally would be, his refusing is impeding him getting to rehab. So I would talk to him about kind of his goals again. Are your goals to get to rehab? Is that something that you still want to do? And if so, then these are the steps you need to take. If you want to remain on the goal to get to rehab, you at least have to be on a dialysis schedule, and if you're refusing, sometimes it doesn't make you the most attractive candidate to begin with. So just being, frank with him and telling him these things, in hopes that there is one of those factors that he will discuss more.
And I would suggest that maybe, somebody could actually go, because I'm assuming that he has to go to another part of the facility for the dialysis and make sure that people are treating him kindly there. If it's cold, is somebody offering him a warm blanket? I mean, somebody who is demoralized, I think all those things are so important, and you can assume that, he's being well taken care of.
Sometimes the refusal is a sense of control by the patient. This is the one thing that they can determine, and if they're in the hospital, there's often a loss of control. So the dialysis schedule may be dictated by how the dialysis unit is functioning, and other patients that might require it at a particular time of day or more urgently needing it. And so he may not have a sense of, okay, now you're being called for dialysis, you have to go. And his only recourse is to say, no, I'm not ready, I don't want to do it. How do we give people a sense of control? Are there strategies for that?
Yeah, I think when, at least when you hypothesize that this control might be part of it, really working hard to find all of the places everywhere that you can give him control. He's been in the hospital a long time. Are there things that you could do to just make his hospital space more attractive and more comforting? Are there things you can do with family members or with other people? Does he have items that he prefers, music that he prefers? Just anything you can do, giving, as opposed to, do you want this, yes, no, maybe giving first choice. Do you want to go in the morning or do you want to go in the afternoon? There's lots of things I think that the treatment team can do to help him find control over parts of his life. And I also think it's okay to have a conversation about our society values control and how hard it is. Maybe this is a person that had control all of his life, and this is something that's so difficult for him. And just to acknowledge what that's like, if you've been so independent your entire life, to be now dependent. I think acknowledging that can often go a long way.
I think sometimes we like thinking about some of the other things and making some of the other things comfortable or diversions or whatever, because sometimes with patients, every conversation we have with them is about a clinical scenario or a treatment or a test. And so then they want to stop talking to us because they're tired of it. They want to talk about something else or do something else. So I think sometimes trying to figure out what are those other things, because his whole life is here right now.
Lisa, I wanted to ask, so you said sometimes the refusals could impact on his ability to go to a rehab facility. Facilities may look unkindly towards that. Do you think it still needs to be documented that he's made certain refusals in his dialysis needs or other things?
Yes. Now how it's presented, because the facility is going to read the medical record before they accept him. But they also need to know what they're getting. So if they're getting somebody that's, not always compliant with dialysis, or, they have to understand, well, we're getting a challenging patient. Otherwise, it breaks relationships with them, and they also don't know how to deal with them. So I think they need to know that he sometimes is refusing, but hopefully by the time he is ready to go and we got him on the schedule, we could say, well, he did, but then we tried X, Y, and Z, and now he's going on a schedule and he's doing fine. That would be a best case scenario.
So some of it is they look at the medical record, but then you'll also have a conversation with the facility representative of trying to explain the case in more detail.
Right, exactly.
Jeff, anything from a legal perspective in terms of these kinds of refusals? When a person needs to be in the hospital, I mean, he can't be discharged home without a dialysis facility. So he sort of is here, and we need to take care of him. We try to negotiate with him, but how does a legal framework come into play with this kind of refusal?
How much time do we have?
20 minutes.
I don't know. Wow. So we have to effectuate safe discharges. from a liability point of view, if we just push somebody out that is an extremist or somebody that's not otherwise stable or safe, the question is are we exposed to liability? And the answer is, especially in Baltimore City, yes. And it's very venue dependent too, by the way. So Johns Hopkins Hospital in the city, in our venue, is a little bit different than, say, Montgomery County or Baltimore County. But from a pure liability question of legal ramifications, bottom line is that patients need to be treated in such a way as to ensure that they're not going to hopefully harm themselves, but respecting their autonomy at the same time, and then finding a proper disposition plan for the patient. Somehow, some way. We've had patients that have stayed here for months and months and months and months trying to find out where they are. And we've been very creative in actually trying to find placement, even up to and including the point of contracting in certain places and paying for it to get them where they need to go, especially if money becomes a major issue for the disposition. So there are ways of negotiating around getting them to where they need to be while not jeopardizing any exposure to the institution or to providers, for instance. So it gets tricky fast. A lot of it's operational, but we would never want to put somebody in harm's way as a result of a disposition plan that is inappropriate.
So let's move it out of the hospital to the outpatient setting. So we don't have to worry about a safe discharge plan, but we have to think about how to best treat a patient. And so case 4, a patient that, a minor, number 1, so parents are decision maker, but it's a teenager who has, increasing autonomy as they get older. So it certainly has a say in their health care, but relying on the parents to make decisions and institute a treatment plan. So Shannon, thoughts about how to approach this case?
Yeah, so this is the story of my outpatient life, almost all my patients. It's incredibly rare, I think important to remember, it's incredibly rare to have somebody that actually follows every single one of the recommendations. I think this is probably much more the routine than kind of an odd case. I think one is really talking with family members over and over again. What's their experience with the medication? Are they having side effects? A lot of the medications I prescribe cause weight gain, sedation. So sometimes it's side effect related, and make sure that we're helping families manage side effects. Some of the medications I prescribe, if you don't take them every day, there's really no, you kind of need them to build up in your system. So if you are only taking them intermittently, all I'm going to do is give side effects and not give any benefit. So I have that discussion in a risk-benefit sort of way. I think as with a 15-year-old, having a lot of discussion with what are the 15-year-old's goals. If the 15-year-old's refusing it from their parents, maybe there's a lot of conflict with the parents. It sounds like maybe she's when the school nurse offers it, her relationship with the school nurse maybe doesn't have nearly as much conflict as it does with her parents. So sometimes there's just ways to even improve the relationship between the parents and the kids, find some other way for the teenager to get it on the weekends. So there's, I think, just a whole host. I mentioned that I am doing in the middle of a qualitative study, talking with families about how they want us to react when they're not following our recommendation. And universally so far, and we're not quite halfway through with recruiting, but every family has said, listen, help me problem solve, but if you feel like it's super important, keep bringing it up. Don't just say it once. And then if I say no, if you think it's important, don't just forget it. And I think that's important. I actually have a personal experience with my dad who, despite me telling him to get a colonoscopy multiple times, I guess his doctor maybe mentioned it once and didn't push him. And so he decided he rationalized, I don't know how, but he rationalized that this wasn't important, and by the time he got a colonoscopy, he had metastatic colon cancer. So I've lived that experience too, and my dad had both me saying that, he's an intelligent person, but he just decided that if the doctor wasn't bringing it up over and over and over again, maybe it wasn't so important. So I also keep that in mind and how to balance that beneficence versus autonomy.
Any other panelists' reactions to case 4?
I think it's helpful for patients and families, like, for it to be really spelled out when something is truly necessary and not protocol. I have a friend with a, fatal blood disorder, and she has really exercised a lot of autonomy with managing her disease quite well. And there are things that she has said, I don't want to do this. Yes, I'll get my blood transfusions, but I'm not coming every 3 months to chat with you for 5 minutes and get weighed. And there was a struggle, but eventually the provider agreed, and she moved to California, and the new provider said, no, you absolutely have to see me. And that provider called this provider here, Hopkins, and she said, no, it works. We don't have to do that. So, I mean, I guess just looking for those opportunities where it doesn't have to be, everything by the book.
So again, negotiation with the patient where possible. All right, let me open it up to the audience. 4 cases, 4 different, concerns, thoughts, questions.
One of the things that I know, I hope that I can talk without a microphone. Can everybody hear me?
Well, use the mic anyway.
Okay, I'll use the microphone. One of the things that strikes me, and I like the focus from the very first case on capacity, and I'm an attorney also, and then also the communication. And the thing that struck me about capacity is it can change. My dad had Alzheimer's, I think of sundowner syndrome, and those various things. And so I can't even imagine in the realm of doing healthcare, all the dynamics just sort of blow me away. But I just like the input from so many different perspectives. It's really, really, really striking. So I learned a lot. Really, really cool.
Sharon, do you want to comment on so nurses that, in the morning the patient may refuse, maybe they're delirious, and later in the day they're a little better. How do nurses generally try to handle a situation like that?
Yes, so I think some of that is really important to give that information to the team, because the provider teams often just come around and they get a very one-point perspective of the patient. So I think it's really important for the nurses and physical therapists and other people interacting with these patients during the day and saying, well, no, I do think that, they understand this. And then I think it's an opportunity for the nurse to really try to understand what's going on with that patient at that time.
Thank you for the discussion. I too really appreciate how each of you really emphasize the importance of incorporating the interdisciplinary team and various perspectives. And I wondered, has there been any observations of noticing a difference in the patient population of people who have received that care from the treatment team who may be open to receiving care versus those who are more apt to refuse care, having not had everyone on board and journeying with them throughout their whole plan of treatment?
Right, do you mean so care providers changing over time, or just comparison of patients that refuse and patients that agree?
Patients that refuse and patients that agree based on how the treatment team at large has been involved in their care over time and how that impacts the relationship and their willingness to really take the advice from those who are insisting that they receive care.
I think it does matter if they are seeing the same physicians over and over, or if they're admitted a couple of times, that they if they're able to see the same doctors. A lot of times they're switching. If they're able to see the same doctor, then they do build a level of trust with them. Sometimes you they even have to give the, well, I talked to your other doctor and we're all on the same team, because it doesn't always work that they can see the same people. But I think it's giving the message of that we're all on the same team, and I think that does make people more agreeable to the care plan if they have now if they've been getting the same message over and over and nothing's changing, they might back off a little bit, but I think it's a matter of trust within the whole institution, that everyone is working here as a team, as well as having the patient be a part of that.
I think we struggle a little bit here in an academic setting because we change teams a lot. And, you know, it is for teaching purposes, but at the same time, everybody has a little different perspective. So if you have a long-term patient, it's hard if people really haven't had the opportunity to develop that relationship with them.
I came across a 1983 article in the Journal of American Medicine, and they did a study on refusal of care, and they took different groups of people who had refused care and went back and interviewed them, and they found that overwhelmingly the source of that refusal was a breakdown in communication and trust. So I really do think that it makes a difference. And also, people were also more likely to refuse care when they had not been informed about certain treatments, maybe when somebody just showed up and said, okay, you're going to this now. So again, the communication is key.
The probably number one issue that we get faced with in the legal department, by the time it gets to us, you know, for somebody's not saying they're getting a lawyer, you know, or they go to patient relations and they file a grievance about an issue, I would say one of the number one root causes is inconsistency of messaging between team members. And so when you get the team together at, let's say, a pre-ethics committee team meeting, just a clinical team meeting, and you start talking about what the goals of care are for that patient, and you start getting providers that disagree on those goals of care, that messaging then gets relayed to the family, and that's the stickiest thing that we tend to see, is when we're not singing from the same songbook. And so oftentimes a remedy to that, when we really have cases of distrust, is having somebody that can be a point of contact, or a longitudinal provider, whether it's a nurse or a provider or a resident or a PGY 2, 3, 4, whatever, that can be the face of the team that then routinely is the messenger about a goal of care. It shouldn't have to get to that point. You know, I think generally we do an okay job, but I agree with Sharon. I think here, generally speaking, because we're an academic teaching center and we have residents and interns and doctors and we're rotating, it's a challenge. So, I mean, I agree with that.
I also think when there are changes of providers and people have different perspectives, how you discuss what the last provider did with the patient makes a big difference. So if you are kind of negative about, like, I don't know why they did that, that can really hurt trust. You know, a recent consult that we just did, you know, I think the team was trying to chase symptoms, and every time they chased one symptom, they caused another symptom. And I think just even had they predicted that, and like when somebody finally got it right, the family thought all the other providers didn't know what they were doing, and finally the fourth person actually got it right. So if they would have just started with the fourth person, and I think if that fourth person said, the other providers actually, I would have done it in the same order as the other providers, or this order was equally valid because we didn't know what the outcome was going to be. I think that there are just ways that you can, when you come on service, that you can help people feel confident with the team beforehand.
Let me pose a question to the audience and see if anyone is willing to answer. So I raised the issue of justice. So sometimes when there's a refusal, and we might designate a point person on the team to have these more in-depth conversations, be the one that works with the patient in an ongoing fashion, especially if it's a long hospitalization. there's a time commitment to that. So that person might be pulled away from other patients because they have to spend more time with the patient who's refusing. Is there a point at which it becomes untenable? Is there a point that the team can say, I can't invest any more time in this person, I need to take care of other patients? Does anybody have a solution to that problem? Okay.
So I work in the emergency department, and we come across this issue a lot because we have people that come into the ED every day, every other day for weeks, months, years with the same complaints that don't follow up with their care plan, and we get consulted for these patients every day for the same things. And so at a certain point, you have to say, am I going to have a 30-minute conversation with this person every day indefinitely? Because that does take us away from seeing the other active consults and the critical cares and the other responsibilities. So I think it's a delicate balance. You don't want to completely give up on someone, but you may have to dial it down. I can't see you every time you come to the ED, but we'll do an assessment once a month, or I'll come talk to you once every 2 weeks. You kind of have to find a way to work with that patient without neglecting the rest of your job responsibilities.
Other thoughts? Other questions about any of the other cases or reactions to the cases? We'll come in the front here first.
I just want to add that all of these patients typically have some mental health undiagnosed or diagnosed in the midst of this, which also creates barriers intrinsically and for reasons we can't even put our finger on. And so I wish that we could talk more about that, of how you manage a person who's who's refusing mental health services, but yet still is in a cycle of some type of a manic episode, but does not acknowledge that that is what it is and that it's causing a barrier to care. And when do we have the ability to discharge somebody? It doesn't matter what they're coming in, what ailment they're coming in with. You know, delivering a baby versus having a laceration on their finger. That's not considered emergent.
So sometimes it's not mania, but it may be psychological distress. A diagnosis or a potential diagnosis that's upsetting to them, and that's impacting them. There might be a personality disorder of something that they're just a pattern of or a cycle of refusals or non-adherence. Sometimes the strategy is some sort of behavior management plan. So how does not only negotiating, communicating with the patient, but coming up with a team plan about how they're going to approach that patient. Can the panel comment about either behavioral contracts that we used to have, or behavior management plans about trying to work with a person that might have psychological issues that are impacting on their decision making?
I would say a couple of things just about just mental illness in general. I do think it's pretty common. Obviously, there's a huge population with mental illness, and patients with mental illness a lot of times actually have more chronic medical needs. So I do think everybody should be kind of aware of that. I think another thing is sometimes when all of us, when we're stressed, we do not use as good a coping skills as when we're not stressed. And so anybody, when you guys are all seeing patients often in very huge, big crises, and so the coping skills they're using may be somewhat maladaptive to the setting. In Baltimore City, there's high rates of trauma. So many of the patients have just had chronic trauma. And so I think getting trained in some trauma informed, just how to speak with people, assume that people have been traumatized, I think can all be important. I think, behavioral contracts, kind of behavioral plans are somewhat difficult. I think, you know, being clear with expectations, what the reason of the expectations are is important. I also think if you can talk to the families and patients about how they're affecting you with I feel statements. So, like, I really want to get you better, and it's hard for me when you refuse dialysis as somebody that's caring for you. So using statements like that sometimes I think can be helpful.
I am not a fan of the term behavioral contract. First of all, contract is offer, acceptance, and consideration, right? I don't even turn this into contracts 101. In patients, you push a contract in front of a piece of paper that says, here, sign this. I mean, that's like the first way to have somebody shut down on you. That doesn't mean that you don't negotiate, have conversations, and collaborate, and try to come up with a plan. And what you call that plan, there's different phrases, like we've started calling these things behavioral management plans, which also has kind of a slightly greasy factor to it in some ways, because what we're really trying to accomplish is coming up with some negotiated plan to get the patient with agreement from point A to point B, and it could involve a whole host of different action plans. It could be just some sort of negotiation about this is what we can do, these are your choices. So the other thing I was going to throw out there too, because I was thinking about this, Mark, since we keep talking about the word refusal, we're really talking about choices. And I know from a legal point of view, we often advise our providers to make sure you document in the record the patient refused. Every time they refused, put in they refused, they refused, they refused. And that's kind of a sequelae of the legal liability piece when you then have discovery and you can put in the record that, hey, see, the patient refused all this stuff. That's one thing. But I think what we're really talking about is the patient's right to make certain choices, and their choices just may disagree with our choice. And then how do we have that conversation with the patient in a way that's not so adversarial? And so if we can get to a better place with better language, we might have better solutions.
Any other points? There was a question on.
Yeah, just very quickly. So I heard one or two of the panelists mention that there may be either a spiritual or cultural component to a patient's decision to refuse treatment or some form of treatment. So my question is, in your experience, have you ever utilized either your in-house chaplaincy services or community faith leaders to join in that discussion, either to inform the medical team or to inform the patient that perhaps their understanding may be incorrect in terms of the religious implications? And if not, why not?
Actually, that's one of the first questions I think we all ask when we get a call from a team for an ethics consult is, you know, social work, the spiritual care, and if it seems like they've been offering, you know, the in-house spiritual care and people have been refusing, then do they have somebody, you know, in their community that they prefer to talk to? But it's really is so important, and again, it goes back to, you know, sometimes they don't want to talk about the clinical issue anymore. They want to talk about some of the other issues that are really germane to them.
And it can also be a means of building trust. So a person from their faith community, either a chaplain, a spiritual leader that's in the hospital that can address their spiritual needs as a means of building relationship and trust, or someone, you know, in their congregation that they really feel comfortable with, that could be a bridge. We advocate for, you know, when we do ethics consults, more for the hospital-based chaplain, because they're also informed, and you're all familiar with this, about the medical issues. So they can do that bridge better of know what the medical condition is and what the team is trying to achieve, but then also address the spiritual needs of the patient.
Can I add something to that? I don't want to leave out the mental health and the spiritual health of the providers. And we have a group here called the RISE team, the Resiliency and Stressful Events team. And interestingly, I love your question because there's not a lawyer in our team that doesn't ask about pastoral counseling when we go through this dialogue with providers, not just for the patient, but for the providers too. Because if you have a very anxious, upset team, then how they communicate to the patient's affected. And so we want to make sure that there is wellness on both sides of that equation, and we try to coach them that way as well. It's so funny because every time we get, I hate to keep pointing at Susan, Susan's my dear friend and colleague in legal, we get somewhere between 600 and 1,000 legal calls every 4 weeks. And I would say probably 60% of that is pastoral counseling. It's not legal. Because what we're doing is we're talking clinicians, coaching clinicians, and trying to understand what's going on and point them in the right direction. And oftentimes you can avert legal issues simply by having those kinds of open pastoral kind of conversations. It's a fantastic question, so thank you for bringing it up.
So to Jeff's point about spiritual counseling for providers, I mean, doing this volunteer work, it's become so clear to me, how rampant provider burnout is and the really serious ramifications of that. So, and I think patient refusal is probably a key trigger for that. So, and that obviously doesn't bear well for patients and their families. So, sort of getting to the root of this is so important.
I have a question in the back. Got to get the microphone to you. This will be our last question, and I'll just have a little wrap up.
Are there resources online to which you suggest to the medical team or the intern resident who's in distress over the case? You go online for everything else. There's so many examples given just here that I can imagine that there are many similar things are online, but the question is, you all have a preferred location.
Fantastic question. The answer is kind of. So we have resources available online to point people in the right direction. And we have RISE counselors that are available 24 hours a day, 7 days a week, 365. There are peer responders to talk to clinicians and to anybody for that matter, even me. I can call them up and talk to them. As well, we have the faculty and staff employee assistance program as well, where they can have an anonymous conversation, a confidential conversation. And so we do talk about wellness, but I think we could probably do a better job of doing that. But the RISE team really has been one of our go-to organizational methods for helping providers get through stressful events.
Yeah, I like the personal touch better. I think talking to another human being rather than going online is probably preferred. If people needed something to help with de-stressing, the institution does have a subscription to calm.com, so meditation practices to just sort of get to that wellness feature. So there are things out there, but again, utilizing resources that are in person and you can call somebody, really have a conversation with them is my preference. Let me just give you a wrap up of some of the things we've talked about. So this is from the Attorney General of Maryland website. This was actually in particular about end-of-life decisions, but this is their strategies for not only making, but implementing healthcare decisions. So it's not enough just to make the decision, but you actually have to implement the decision. So I think we've talked about these things. What are the care instructions? Does the patient have an understanding of that? Clarify the medical issues. Determine that they have capacity. Does the patient serve as the primary decision maker, or do they need someone to speak for them, a surrogate decision maker? Make sure you're really describing the healthcare issues that they need to make decisions about. If it's an ongoing condition, you're updating those care instructions as needed. You're giving them choices, so you're really laying out the range of options. And then you're reviewing the situation, continually modifying it as needed. So that's that part of that ongoing negotiation with the patient or family. Just in schematic forms, you cannot see these boxes, so I will skip it. But it's that same strategy. Does the person have capacity? If not, who's the decision maker? How do you work with that primary decision maker to get to a plan that you can agree with? And then a couple of other things that we did touch on. All comes down to trust. So focusing on trust building, talking about expectations. So that negotiated plan with the patient is setting expectations, reframing expectations, finding out from the patient, what does success look like to you? What are the outcomes that you're hoping to achieve? Because trauma is such a key element in a lot of the patients that we do take care of, so screening for trauma, having trauma-informed care, really knowing what the triggers might be for this person and how to overcome those. Reframing patient behavior, so how do you work with the person to get them to yes? Try to connect it to the treatments that they are wanting to achieve. Try to have consistency across the interdisciplinary team. That might be a designated person that serves as a spokesperson for the team. And then if there is going to be any kind of behavior management plan, that's reevaluated and worked with the patient and family to achieve the best success. So we will end it there. Thank you all for your participation.